And then we're going to share to the PowerPoint. And y'all should be able to see that, right?
Yes.
We talked about the safety needles. We talked about insulin. And I think this is where we left off. We were going to start into syringe and syringe sizes. I posted quite a bit of stuff. Actually, real quick, before we do that, let's take a look at screen share my actual Teams. Where's it at? Right here. Y'all see the Teams page?
Yes.
Okay. For whatever reason, the videos themselves don't load. But y'all always know it's a lecture because I put lecture here. And then I put a couple of other information sheets here for y'all. And I hope everybody went through them. They are printable if you'd like to print them. But it's just talking about how there are many different types of syringes. And that picking one up and not knowing what dose it's capable of administering can be dangerous. Just like there are many types of needles, and picking out the right length and the right gauge, right? And this shows how big it is. So you see how large a 15 gauge is, 18th, and so forth. So making sure you have the right equipment for the job is vital. And then I put together these little bits of information. This is basically each one of the injections that we do. It's like a little cheat sheet. It tells you usually what gauge we're using, but these intradermal, we usually have what's called TB syringes, and that's usually what we can use. But if that's not around, it lets you know, and no more than 0.1 ml can be administered, and that you should use right around a 25 to 29 gauge. So that's tiny, 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 and talks about that you never aspirate. And like I was telling you, with TB, you want to see that bubble, and this walks you through the steps. And then I did the same with the subcutaneous. And the subcutaneous showing that it's going into that fatty layer. There's a 45-degree angle, and then it's talking as well with your needle gauges, the length, and how we do not aspirate. Okay, and this is giving you more of the instructions. And then lastly, the intermuscular, and we see how it goes in straight because that makes it a 90-degree angle here. And usually we're going to be a 20 to 22 gauge, and it's going to be a 1 to 1.5. And that's going to be dependent on the size of your patient and the area in which you're giving it. But the degree is always 90. And we do it in a darting motion. And if you've ever played darts, that's exactly how I train my MAs to do an injection, is to hold it just like this and do one quick swoop. Don't hesitate. If you hesitate to go in with that injection, you're going to poke them and it's going to hurt, and they're probably not going to want you to continue with what you're doing. And you don't also want to jab. So you want to do a quick dart, just like real fast darting motion. Now, this is where the controversy comes in. It says to aspirate. Now, I don't remember what your book says. And what aspirate means is to pull back on the plunger slightly once it's in the arm or the hip area, whatever, to see if you have blood in the syringe. I would say 90% of all of my students come back and tell me we do not aspirate. My sister-in-law, or like I said, she's a pediatrician. They don't aspirate on IMs. And I asked my brother-in-law, they aspirate on IMs, and he's like, no, I don't have my nurses do that or anything. So most doctors, most nurses, that's not something. Now you may go someplace that you got some old school person that's, like, oh no, you better aspirate. So you always, if they tell you, oh, you aspirate on your IM injections, then that's how you do it. If the person training you, when you go in, says, oh, you aspirate, then you aspirate. Do what they tell you to do, because we are fluid and we go with it. But just know that most places do not require it. And this is telling you the good sides that you can give. And then I am also going to show you a really cool video on what's called the Z-Track. And it's basically all you do is you just pull the skin before you give the injection. That way, when you let go of the skin, the medication doesn't kind of ooze out, right? And like I said, I'll post the video. And then I also posted this picture here. And then it's imperative. And I stressed this yesterday, and I'll stress it again. Just because you see, okay, oh, orange, it's insulin, okay. But look, you see how there are different sizes of insulin unit? This is a 30 unit, 50 unit, 100 unit. Randomly picking up a syringe is never okay. You always need to know what you've picked up and put in your hand. And it says here, insulin syringes come in different dosing sizes. Make sure you pick up the right one. Insulin does save lives, but a mistake with insulin can end somebody's life. And that's not me, making jokes or anything like that. That is me being 100% serious. I have seen it. I've seen this done. And there's nothing you can do about that. We don't want this, okay? And then the last part of our video. So now I'm going to go back here. And I'm going to stop that screen share. And then I'm going to go back to our PowerPoint. Okay, we're back and everybody can see my syringe PowerPoint. And so kind of getting an idea and a picture of the syringes, and like we were talking about, that the larger syringes, I've seen syringes that were this big around. So they're used for like irrigation or boluses or stuff like that, okay? But the most common we're going to be working with in the office is a 3 ml to a 5 ml. Those are real common. And they're the most accurate when we start thinking about our small doses. Okay, how many of y'all, does anybody know what the word viscosity means? I'm trying to wake y'all up here. Anybody?
Thickness.
Yeah, that's exactly right. How thick something is. And we choose the gauge of our needle by one, the size of our patient, but two, the viscosity of the solution we're going to be administering. And I will tell you a story. When I was pregnant, I worked for a doctor as an MA, and was a paramedic as an MA. And I was used to paramedic drugs, and most of them are very thin, liquidy viscosity, and just go straight in. Well, I had never worked with gentamicin or Rocephin. These are antibiotics. When I tell you their viscosity is like syrup, um, I'm not joking. And I had no clue. And I'm sitting there and I get my injection ready and, and I'm glad I chose the glute area. And I tell you, it took pressure. I mean, to like literally get all of that medication in because it's so thick. And some of your antibiotics and steroids and stuff like that, they may be that way. So you don't, and the reason it took so long for me is because I chose the wrong size needle. So that was my lesson learned. And after that, I always made sure when I knew I was going to give somebody Rocephin or penicillin or not really penicillin, but oh goodness, I just gentamicin. Oh my goodness, the Rocephin and gentamicin are the worst. So I always picked the right size needle after that. No mistakes. Now with like I said, some of the clinics you'll be working, if you're working at a pediatric clinic or adult general practitioner type of clinic, you may be giving lots of, and the doctor says, hey, they need somebody comes in with an STD. It's really common that the doctor will give them a shot of something like Rocephin or something because it's a really strong antibiotic, kind of to knock it out, and then send them home with medication as well too. So it's not uncommon. Okay, so got to be familiar. It's not something it's not like it's never gonna you'll never run across. Now I've already talked about how needles are categorized by their gauge, right? The size of them and their length. And we talked about how that extremely big needles have a smaller number. Like their gauge are 10s, 14s, 18s. And that when we start thinking about more practical gauges that we'll be using, we may use an 18, um, but we're probably going to be seeing and sticking with more of the 20s and 22s and stuff like that. Okay. Um, I I would say if you had a big person and you had to give them some Rocephin, I'd pull out the 18 gauge. And then the needles and the needling. Like I said, I gave you the diagram. I'm not going to spend too much on this because it's a picture. You need to visualize, and the best way is to hold. When you see it in your hands, you see the difference. When you have your patient next to you and you're inspecting that patient and seeing, their body mass. I'm a big girl, so I've got a lot of extra, fat, muscle, and I can handle for me, for IM, I'd probably go at least a 1 to maybe 1.5. If you're going back in the my glute, you're definitely going to need a 1.5 because you need that extra length to get to the muscle because of the extra fat or adipose area, if that makes sense. And then we've talked about that. I'm going to post a very important video. It is a OSHA needle stick safety video. It is imperative that y'all watch this. Okay? It's going to be one of the ones that I put on there. Even everybody has to, even if you're watching and here with me now, you're still going to have to respond to the video. And because OSHA stands for, I know we talked about this before, Occupational Health, Occupational Safety Health Association or Administration or something like that. But basically, wherever you work, that's they have their guidelines, but they are controlled and mandated by OSHA. Okay, and there are very strict guidelines that certain things, if you mess up and you do incorrectly, the entire business can be shut down. So we don't want that. We don't ever want that for where we're working, and we don't want that for, the risk of you losing certification if it come back on you. So everybody will watch a video and respond to the video, okay? I talked about the different types of needles and how they have different needle guards. This will also be in the video. And then we talked about the recapping. All right. I told you that we avoid or we try not to recap, but there are instances where we do recap because we have to change out a filtered needle, or we recap because we need to put it, on a tray or in our scrub top to, for our PD patient that we don't want them to see us coming with it. And how do we one cap? Recap. We recap one-handed, and like I said, if I had you in lab, I'd really make you take your non-dominant hand, put it behind your back, and just like that diagram with the picture that I showed you, you have to pick up using the needle. You pick up the cap, and then once it's on, and you wiggle it down, and then you can click it. And the reason that we take this is because these precautions is because it's too easy if you're holding the cap here and the needle here to make a mistake, slip, and stick yourself with the dirty needle. And the reason that we don't do it with clean needles, why? Because you do not want that muscle memory. You do not want that to be something that's in your mind that says, okay, I'm going to just recap. And then one day you do it with a dirty needle and get stuck. Okay, so this is why we don't do that. And this is showing you the safety needles. These are neat, but they're expensive and not a lot of places have them. And basically you prepare, you inject, and then the needle withdraws. Okay. I skip over that really quick because they are expensive and I don't see a lot of places with them anymore. When we're finished with our needle, all right, one of the very first things I would be having you do in lab is immediately place it in the sharps. I've had a lot of people question even other instructors because even during blood draws, your patient might be sitting there, you put the gauze, right? You have the needle, you can hand them the patient. I always interact with my patients when possible. Have them place the gauze, bend their arm, and then before I do anything, I dispose of my needle. And there are a lot of people that set their needle down on the tray. Or there are a lot of people that'll one cap it or this or that. I don't do that. And I've come across people who have, oh my God, because I'll let the patient's, blood trickle because it's a vein, okay? And yeah, there might be some blood coming down the arm. I'd rather come back and clean up a little blood off my patient's arm than accidentally stick myself or someone else with a dirty needle. So I am very OCD about getting rid of my sharps the second that they're used, okay? And a sharp should never be placed in anything but an appropriate container. And that appropriate container is the large plastic biohazard boxes that are designed to be puncture proof. Sometimes, and they come in different sizes and shapes. I've seen little round ones. I've seen little boxes, big boxes. There's even the big, massive needle disposals. Now there is a difference. There are in our labs we have trash cans that you can push with your foot, and they have red bags in them. Those are not for sharps. Okay, Those are for biohazard waste. And I explain this to you, and I might have already talked to y'all about this. That is for like somebody vomits and you have a large amount of vomit to clean up. Somebody has diarrhea and there's feces to clean up. A large amount of blood from an injury. Uh, Things that are going to, somebody's water breaks and you've got to clean that up. So something that is large. We do not put anything in, and I could trust me, I could be keeping you from either getting written up or fired by listening to me right now. Those trashes with the bags, a company picks them up along with the boxes, and the doctors pay a certain fee based on the weight. So if their average bill is $300 a month for their biohazard waste, and then you come along and you start working and now it's $1,400, $1,500, and they start wondering why, and they look through and say you've been putting all of the bed trash, like the paper from the bed in there, or you've been tossing your, McDonald's cups in there, or dirty baby diapers, stuff like that. It's going to start adding up weight wise. And what ends up happening is their bill is going to skyrocket. So there's a very specific thing that we put in there. And like I said, it is large. If I had a piece of gauze, right, that has a drop of blood on it, does it need to go in there? No. It can go in the trash. Small amounts of things can go in the trash. All right. A Band-Aid that's bloody can go in the trash. Somebody had a bloody nose and you throw that in the trash. Okay. People are very misunderstanding about what that biohazard trash bag is for. And it's for large quantities. All right. And it's imperative that you understand it is not for needles either. Okay. Needles only go in the approved Sharps container. Vials is the next thing we're going to get to. And we're going to, several of my videos have already shown y'all working with a vial. And a vial is basically a dose of medication that, or a type of medication that contains many doses. Are there single dose vials? Yes, there are. But for the most part, what we're going to be seeing in the doctor's office clinical type settings is the larger multi-dose. And the reason that they have that is so that it's less, it costs less as far as ordering, and it can be reused multiple times. And there's a reason that right now I'm going to go over some rules with you. When you have a vial, even if it's the very first time it's been pulled out of the box and you're the one that gets that's a very satisfying thing to flip the lid off on a vial. We're still going to clean it. We're still going to take an alcohol prep. Even you're like, well, it just came from the manufacturer. My OCD doesn't allow that. We clean the top of the vial. And that's because we're going to build that muscle memory of always cleaning it. So every time you pick it up out of the lab refrigerator or the lab cabinet or whatever, however it's kept, you're always going to wipe that top of that vial down and let it dry. And the reason we do this is now we know that it's clean. All right. And that's always one of the first things we do. And I mentioned this a few other times. While we're pulling that vial out of the fridge or the cabinet, what are we doing? We're giving it its first check. We're looking at the drug, we're looking at the name, we're looking at the expiration date, we're checking its clarity, and we're making sure that it is the right drug that we need, right? Because how many times do we check a medication? 3. 3 times. All right. You may see some medications. Actually, what's really weird, I dreamt about I know, here's how weird I am. I dreamt about a drug called Solumedrol last night, and it's a steroid. And it's really cool because it's a vial, it has a neck, and it has another area. And when you go to use it, you kind of have to push this down to activate the powder. All right, so it's 2 separate compartments. And for whatever weird, odd reason, I dreamt about it. I used to give it a lot in EMS, but that sometimes there's little rubber stoppers inside of them as well. So that's not uncommon, and that's to protect the medication that's inside of it. Now the needle, before, like I said, before you insert it, that vial is always going to be clean. Before you insert that needle, make sure that you're using the correct syringe. All right. We can always change the needle out, but make sure you're pulling it up with the right syringe so you know you're pulling the right dose. Okay. Now, if a vial is a single dose vial, that means you would not put it back in the fridge or store it. It's when it's finished. If it's glass, it goes in the biohazard. Okay. If it's a plastic one, it goes into, depending on the doctor, either the sharps, the the biohazard bag, or the trash. That's going to be doctor dependent. Okay. And then your multiple dose vials, those usually have, like I said, many times we'll pull from them and they'll either go back straight to the refrigerator after we've checked it for our 3rd time, or back on the cabinet or in the lockbox or wherever. And it's at 35 minutes, so I'm going to go ahead. I'm going to leave y'all here. These procedures are what we've been talking about. These are talking about checking, wiping, withdrawing the medication, removing air bubbles. I have a really nice video I'm going to post for y'all. So that's 3, right? Yeah, it's 3 videos. And then I'm going to stop here with ampules, okay? But all of this will be in the video that I show you. And I'm also going to show you that OSHA video, okay? And I'd like everybody, like I said, to comment on that. Does anybody have any type of questions, comments, concerns, complaints, or anything they'd like to add for the morning? Crickets.
No, ma'am.
Okay. All right. Well, y'all have a wonderful day. If you haven't done your SurveyMonkey, please get that in. And remember, when are projects due?
Tomorrow.
Tomorrow. That's right.
Friday.
That's right. And I've already gotten some of y'all's, and they're amazing. So
Yes.
I'm really impressed so far. All right. Y'all have a wonderful day. Make sure you hang up.
Alrighty.
Bye-bye, guys.
Thank you. Bye.
Hang on. Look at the dog.